Our next and final speaker for the morning is David Meldrum, and it's very exciting to have David here. It's great that he's agreed to travel all the way from Canberra or South Australia or in between to come to speak to us today. David was really one of the questions raised earlier by Stephen around the ideas behind the Partners in Recovery program. Really, I think David can really address a lot of those, because David was on the expert reference group that worked with the federal department to develop the Partners in Recovery program, so hopefully he'll give us a lot of insight into the thinking behind it, and also an update on where things are at nationally, because David is really touching base with a whole lot of Partners in Recovery initiatives around the country. David is the Executive Director of the Mental Illness Fellowship of Australia, and he's here to discuss the rollout of the program. So thank you, David.
It's going to, in 2 months' time, it's going to be 3 years since this was announced. It's taken a really long time to get rubber on the road. It's $550 million, 24,000 people. You probably want to know where that 24,000 came from. It was the amount of money that was available divided by a figure of, I can't remember, the $1,000 per year average, came to 24,000. Then they looked around, a number of people looked around for a way to make sense of that, and it was a bit less than half of the people that were believed to have severe and persistent mental illness, which is all we're likely to get to in 3 to 5 years' time. That's how policy gets made. It's an inductive bit of reasoning that led to the 24,000. The 60,000 figure is a very, very woolly one, and it's important that you recognise that, because it'll show up in the referrals you get. There are somewhere between 200 and 250,000 people with schizophrenia in Australia. There are somewhere between 250 and 350,000 people with bipolar disorder. That's just the psychoses to start with. Who gets defined as severe and persistent with complex interagency problems in all of that is a series of accidents and artefacts, as well as severities of conditions. The referral pathways that people come along label them in certain ways. So don't believe a word of that 60,000. It could be anywhere between 50 and 150,000 people who would fit that description. And that's important, because you're going to get referrals from a lot of people who believe they know a severely and persistently mentally ill person with complex interagency problems when they see them, and you might not agree with them. So that 24,000, I always think of as going to be, in effect, the too hard basket of whatever that number is. Let's not forget that. Just for example, there are a bit over 80,000 people who've made it to the long-term continuing care caseloads of the public mental health services. And you know how tight they are about eligibility. So there's over 80,000 to start with. Okay. From the beginning, I'm saying there, the concept had many critics. Mark Butler went around the country talking to a lot of people in, 2010, when he first became the Minister for Mental Health. And he says he consistently heard the theme from people. It's not just that there are gaps in services, it's that it's an incredible muddle out there, and he particularly heard this from carers, that if we didn't try and make some sense of it, nothing would ever happen. And so the load comes down to us. And he came to the conclusion that the mental health, I was going to say system, but the mental health scene, because system is too much of a compliment for it, the mental health scene is one in which rather than spend all the money on yet more new services, somebody needs to make a decent-sized investment somewhere in coordination to try to get a better result, a better bang for the bucks. Remember that theme when you're thinking about your critics in the current government. A better bang for the bucks is an important theme that doesn't it's not too hard to translate from a Mark Butler's vision to a Conservative vision. He was under a lot of pressure from a whole variety of people, me included, to fund many more FAMS programs and many more HASI programs and things like that. And he held the line against many of his own cabinet colleagues. He said, the last thing the world needs is more case coordinators. For heaven's sake, there are gaps everywhere. My electoral door is battered down daily by people saying there's no service for my kids around here. But he held the line and said, we have to make an investment in coordination sometime or another. Let's do it now while we can. And he got away with it. So he had many critics in his own party As soon as he announced the idea, his critics became legion. And it was in fact quite hard to find supporters. One of the things that happened then, unfortunately, I think, was that the department started talking about it as if it was a new service, which was to be run by support facilitators and would step into the breach where others had failed and provide a new U-Butte service that would get people's recovery on track. That was a wrong reaction to the criticism. The reaction to the criticism should have been and remains a cogent explanation of how a coordination program for people with exceptional needs has to work. This is a bit twee, I know, but it's just a picture we've put together in my office, and it's lots of the domains are up there. Many more could be put up there. Is child protection there? Yes, it is. You know, I'm sure I could think of something. Is jails there? I suppose justice. The world of a person with severe and persistent mental illness is incredibly complex. There are so many players in it, sometimes all at the same time, but they rarely know about it. That's not news to you. I think when I was studying social work in 1977, we used to put similar diagrams up and talk about seamless coordination, integrated care and coordinated care. You've done it all your life, I know. The room's full of you who've been doing this. What do we mean when we look at that and say we're going to make wraparound services for somebody? I think what it really means is that you're going to look at that array and think, what are the key linkages this individual needs? And you'll be doing that serially, one by one. But you also need to have a lot of your intellectual capacity in your Partners in Recovery program. What are the common groups of linkages that are needed in this area that we're going to work on? So, for example, with an individual, they may be bouncing out of jail into homelessness and harassing their family. So, you know, justice, housing and home support, child protection, the police aren't up there, I suppose they're part of the justice system. And also refusing to deal with Centrelink because they've got an anger management problem with Centrelink, which many of us share. So they end up in a muddle that ends up in being arrested and back in jail within 6 weeks or so. That scenario plays itself out constantly. I'd be surprised if you haven't come across one yet. What are you going to do about it? As a support facilitator, what can you do about it? What's a support facilitator going to do about housing priorities, about child protection priorities? How are you going to get those agencies talking together and then work your way through the Centrelink thing? A support facilitator on their own, in my view, unless they are dead set genius with a short lifespan in the job, are going to be cannon fodder in that situation. They're just going to beat their head against the same brick wall that all the previous case coordinators and case managers have been doing. Policy change comes at a higher level, at a level of complexity that needs some seniority and some experience in this sort of work. I was saying to someone at the tea break that one of the people involved in the expert working group said, you know what, I think this might actually be rocket science, after we'd thought our way through what was actually involved in this program. Okay. Oh, by the way, it actually originally developed that to persuade clinical staff that 80% of the work is about getting a life back and only 20% of the work is about managing mental illness. So I just have to acknowledge that. That's what we actually made up that slide for. What are the challenges you're likely to meet? I think this is important because if you talk to most people about mental illness, they won't start talking about challenges in the way that people with mental illness do. This is from Vera Morgan's big study in 2010 of 1,825 people with psychosis in Australia, all on the long-term caseloads of state mental health services. So bear in mind, that's not everybody, because only about half people with severe and persistent mental illness make it to those long-term caseloads. But that group, when asked the question, what's the biggest challenge you face in the next year? The first one was being broke. Now, you will not see expert psychiatrists and other clinicians, and even many of us on telly talking about mental illness and mention the fact that the #1 priority for most people is they're broke. Is there something you can offer to them that will get them out of being broke? The second one is that they're lonely. Yeah, well, we start to talk about loneliness a bit and social isolation. I think David Best's talk just reinforced tremendously and very eloquently what we all know, how fundamental that is to establishing a recovery pathway. The next one was lack of employment, something to do during the day, some constructive activity from which I'm valued, and hopefully I get some money as well, to suggest as the first problem of being broke. And the next one was poor physical health. The most common sentence they heard is, I'm sick of feeling like shit all the time. And they weren't talking about their mental illness, they're talking about their physical illnesses. Now, you all know that intellectually, but your client group will be some of the illest people for their age group in the community. They'll have 5 times the rate of diabetes risk. They'll be smoking an average of 66% of them will be smoking more than 25 cigarettes a day, etc., etc., etc. It's only when you get to the next one, not my mental illness even, but the uncontrolled symptoms of my mental illness. The challenge is not that I've got schizophrenia or that I've got psychosis or whatever. It's when those become uncontrolled symptoms where I can't get on with my day at all. People aren't actually looking to be disease-free. They're talking about the uncontrolled symptoms. And incidentally, it's only after that that we get to things like housing and stigma, which is where we usually spend all our time talking. Those are the challenges as perceived by people, many of whom will be referred to you. Just as a quick thing, it's interesting how the picture changes once people are over 50 and have a severe and persistent mental illness. The poor physical health has come to number 1, which is not surprising, because if you've got schizophrenia, your average life expectancy is 54 years. It's been studied repeatedly over the years, and in fact there's a good study from 1912, and the average life expectancy of a person with schizophrenia in 1912 was 54 years. We've made 0 progress on the life expectancy of people with severe and persistent mental illness. It's really interesting also in that study to look at what people said about why they couldn't get a service, even though they knew they needed it. This will be highly relevant to you in terms of some of the things that David was talking about. You know, this isn't for people like me. The biggest reason was that they believed it wasn't available. The next was they didn't know where to ask. Sorry, it wasn't available, it wasn't affordable, they didn't know where to ask. Some of the time they'll be right about all 3 of those. A lot of the time they won't be right about any of them. And that's going to be part of your job, changing those belief systems. How is it actually supposed to work? From the start, 2 or 3 people on the expert working group, me included, found ourselves really working uphill against that fundamental criticism that this was meant to be about system change and coordination and not about new U-Butte therapists leaping into the fray and proving that they could turn people's lives around where other people had failed. It was about value-adding, capacity building, working with the existing strengths of the community, sustaining them, developing them, and helping an individual get a better deal in that region. This is not new territory. There have been exceptional needs coordination models in a variety of fields: offenders, drug and alcohol, intellectual disability, aged care, mental health, borderline personality disorder. That's just what I know of, working in Australia for as long as I can remember. They come and they go. Some are well-resourced, some aren't. But as usual, when governments get a rush of blood for a new program, there was a year 0 management view. That is, nothing good could have possibly happened before we came along. And a lot of the really good programs didn't get thought about very much. Now, I was talking to, I've forgotten your name, Mabruka? Yes, Mabruka Singh at the break, which is a fortunate conversation because I had not heard of the, say the correct name of the program? The Multiple and Complex Needs Initiative that operates in this region. Now, I should know about it because I had a good long conversation with her and it sounds fantastic, but it never came up despite a large fleet of Commonwealth public servants allegedly researching everything that was going on in Australia as we developed Partners in Recovery. I knew about a couple of others. I knew about one operating in Queensland called the Services Integration Coordinator, the SIC. And I knew the strengths and weaknesses of that program as perceived in Queensland. But there have been models like this around for a long time, and they always have their critics, but the successful ones stick to their guns of trying to change systems as they're working with individuals. It's transitional support, building on individual supports. If you like, whenever you start with a person in an exceptional needs program, you are starting with how am I going to create a sustainable solution for this person that doesn't involve me? I'm moving around the country talking to lots of support facilitators and managers, and I think, to my amazement and delight, the majority get that. A minority still don't. A minority are still thinking of themselves, either openly or covertly, you can see it coming through in some of the answers, as the breakthrough therapist who's going to succeed where others have failed. Yes, I know of one Partners in Recovery until at least the other day, and I hope the Department of Health has spoken to them now because we brought it up in a meeting the other day, and they said they would, who've said if anybody's got an existing case coordinator, they can't be referred to our Partners in Recovery program. Now, I find that astonishing. The notion of value adding has just been scrapped at the first base. The notion of building on what's out there, the notion of a person coming forward from an agency and say, we've established a trusting relationship, we can do so much, but we can't do anywhere near enough to get this person on a recovery pathway. Can we hang in there? Can you help us? I would have thought was absolutely fundamental to the design of this program, and yet they've actually said, no, we won't take clients if they've got an existing case coordinator. So it's about transitional support, building on existing support. Just a nice, bland, simple sentence. But every member of the team in your Partners in Recovery needs to know what that means and needs to build that into their work style. It is not the typical work style of most people in the mental health system. There are 60,000 people, 30,000 in the clinical mental health services and 30,000 in the community managed mental health services in Australia. And very, very few of them have this brief, this mandate. You do. Capacity building, I've already said it. The key thing that I think people overlook about Partners in Recovery is the genius of cutting Australia up into regions. Now, whether or not Medicare locals are the right regions is, and I'm sure some of the regional boundaries will get shifted during this Medicare local review, but the notion of chunking the place up into manageable regions where a bunch of people could get around a table like this and make some of those connections is fundamental. To say to you, no, you don't have to solve the problems of Australia. You've got 750 people, we think, roughly in your area that you need to address over the next 3 years. And we want you to work with them and produce observable change, improvement, suddenly makes the whole thing doable. And that's what you've got. Victoria's too big. New South Wales is too big. Western Australia is too big. To tell you to change the system across the whole state is too much. But the regions give you a chance. The flexible funds. One of the key things about exceptional needs programs, and this is an argument that I've seen go on over the last 35 years, and it goes in one direction or the other. No, we don't want flexible funds because what people will refer to us for is money. And it's money for temporary solutions that will not provide sustainable capacity building. So we don't want money. Or we want tiny bits of money only for extreme emergencies so people can get taxi vouchers or buy people a cup of coffee or perhaps stock their fridge, but that's it. We don't want anything that will tempt people into temporary expensive solutions that are never going to last. The other group says you've got to have some decent walking money to get people through a crisis particularly, to get some breathing space, to get the right people around the table to start to create a solution. And we're prepared to manage the risks of making unsustainable allocations of funding. We're prepared to manage that risk. Some people go even further, and I would, which is that money is there to do whatever it takes to get to first base on a recovery pathway. The fewer rules around it, the better would be my view. I'll come back to that in a minute. And it's based on partnerships between agencies. Relationships and partnerships. We debated at huge length in the expert working group about what to do about partnerships. And we very early on made a decision that we wouldn't want a submission to come up without a consortium. Looking back on it, I think part of that thinking, for several, and I've had this conversation with several of the people involved, was not proactive, it was defensive. And that was, let's make sure no one grabs all the money and runs. Let's make sure the Medicare local doesn't grab all the funds and then do it their way and not get it right. Let's make sure that avaricious big mental health NGO that we all like grumbling about doesn't grab the money and do it its way and not let anybody else in. Let's insist that there's a consortium. So that it was partly defensive. But it was also partly idealistic in the sense of we need to get the people around the table who can actually make decisions that will change things in a region. What we didn't anticipate was that groups of mental health NGOs would get together with or without a Medicare local and form a consortia. There's quite a few consortia around Australia which contain essentially only mental health agencies and the Medicare local. That's an echo chamber. That's all the same people talking to each other who talk to each other all the time. It's got nothing to do with that big diagram I showed you before. Where's the Centrelink? Where's the corrections? Where's the domestic violence? Et cetera, et cetera, et cetera. And so we ended up not quite predicting correctly how it would turn out. And we've ended up in a situation where who's the actual management committee of the Partners in Recovery? And I've been to a number where it's essentially the Medicare local and 4 or 5 mental health NGOs. That doesn't cut it. That's an echo chamber. The next bit, interagency work. If there's anybody here who's been involved in mental health or virtually any social service who hasn't wasted many of the years of their youth in interagency committees, I'd be surprised. I spent 2 years on one that tried to come up with a common referral form. How many people here have worked on a common referral form? Just have a look. Those hands start. I'm getting about 10 or 12 hands up. I wasted years on it. The Commonwealth Government spent nearly $500 million trying to get a common referral form accepted across community services and failed. That's just trivia. It's nothing to do with common referral forms. Don't get sucked into common referral forms. This is big stuff. This is breakthrough collaboration to establish real working lines between some of those domains that your clients need you to make lines between. And you won't be the first person to have thought of it. In that scenario of the person coming out of jail, of course you're not the first person to have noticed that. And you're not the first person to have tried really hard to fix it. But now you're in an organisation that's purpose-built to tackle that level of complexity, that level of interagency complexity. The normal stuff, the committee that sits around and meets every month, it goes nowhere near what I think of as breakthrough collaboration at senior level. When I was talking before about the, I've gone again, Multiple and Complex Needs Initiative, got it. The word panel came up in that discussion. It's one of the things we lost in translation in the expert working group. Early on in the piece we said that they all have a panel which does have all the key players on it, and they're the key players who can actually make policy for the half-dozen key agencies that interact with the lives of people with mental illness. That should be the management structure of PIR, and somewhere we forgot that and got into a muddle and ended up with consortia. So you're looking for real sustainable solutions that have eluded good people. One of the key things I noticed during the first few months of discussion about Partners in Recovery was everybody was talking about how the system had failed. Well, that's not completely true. Maybe you need to be as old as I am. But I'd have to put it like this. In 1985, had I imagined the range of services that are available now, I would have thought it was nirvana. Things have improved wonderfully. It's not just that the amount of money in the system has improved, which it has, it's more than doubled. It's not just that there's this fantastic new non-clinical range of services. That's part of it, and that's increased exponentially. But that you see now a reduction in stigma in the community. I was on a plane the other day where a woman's, I had these many conversations on plane, and this woman said to me, "So what do you do?" And we got it. And I was talking about schizophrenia for a while. I was going to a meeting about schizophrenia. She said, "Well, I've got bipolar, and my sister's got bipolar, and my aunt committed suicide. We think she was probably bipolar, but we haven't got any serious mental illness in our family. And I thought, boy, we've only got one to go. We've only got schizophrenia to go. And the other day in a meeting in Canberra that Richard was at, actually, it's the first time I've seen this happen at a meeting, the consumer representative said, no, I don't want to do teleconferences because I hear voices all the time and I can't concentrate in a teleconference. I want face-to-face meetings. Should be happening more often, but that's the first time I've seen it happen in a senior level meeting. The other day I was with a bunch of 7 CEOs in the mental health sphere, and after perhaps the second or third glass of red wine, we started talking, and 3 of the 7 quite often hear voices. That's the first time I've ever had a conversation like that amongst my real peers, very senior people. Stigma is starting to break down, even the final barriers are within reach. So a lot's changed. These are things that have eluded really good people and really good systems. This is really the too hard basket. Don't begin imagining that good people haven't been trying in this space. This might seem a bit trite, but if your organisation doesn't work as a well-functioning organisation, it won't achieve anything. I'll talk about a couple of things. One is, one of the first key principles of management is that you need vertical alignment. The customer, the consumer, the client, whatever you want to call them, the frontline worker, the manager, the board, the CEO, the whatever it is, and the funder. If their objectives aren't in alignment, it ain't going to work. So those Medicare locals and those I shouldn't say Medicare locals, those regions that are charging off down the road of a primary focus on one-to-one work, essentially case management, they are not in alignment with the objectives of the funders of this program, and they will therefore not succeed. So the first thing is vertical alignment of those. Do you have a recognisable management structure that has the same ideas about this program as you? Do your colleagues, particularly those of you who have support facilitators in half a dozen agencies, do they actually agree with each other about the core work that you're doing? Well, they need to. The second thing is about any organisation that's functioning well is that it has a strategic plan, or I might call it something else, but it has a plan. It's got a plan. And that plan for the next year contains only a very few objectives. If I go back to that slide with all those potential connections you have to build, you can't do more than a few of those in any one year. Has your organisation identified yet the 2 or 3 key interagency linkages that you have to get working differently this year in order to start helping whole cohorts, whole groups of your clients, not just the one you're working with at the moment? Have you identified those yet? If you don't identify, you won't work on them systematically. You'll leave it to the front line, the support facilitators, to muck about in coffee meetings with low-level people. That will never cut it. Have you identified those, and have you identified about the right number that have got a chance of being able to look back in a year and say, yes, we fixed this, this and this? I'll give you an example of that relates to the scenario I was talking about before. In Dubbo, the PIR there has got a system going where people who are coming out of jail, who've got a severe and persistent mental illness and fit the PIR criteria, get a gold pass to the top of emergency housing if they haven't got somewhere to go. Up until now, they've been at the bottom of the heap because they've been in jail, so therefore they've got a home, so therefore they're not a priority, and they've had to register and work their way up the priority list. So they come straight out to homelessness. So in that cycle I was talking about before, they've identified they've got whole groups of people out in Dubbo in that cycle, particularly males, and it leads to mayhem and further trauma for the family and for their children, etc., and other community safety risks. They get first priority automatically because the PIR has accepted them as a client, and if the PIR has accepted them as a client, they go straight to the top of the list. Now, I don't even know whether the Housing Commission in Sydney knows about that deal. It doesn't matter. The regional manager has accepted that deal. They're next going to work on the child protection people, that when the PIR accepts a client, that they get a very high priority for immediate allocation in the child protection if they ask for it. So they've developed this concept of the gold pass for one of our clients, and they're starting to make it happen. I'll give you another example, a completely different sort of example, in Perth, in the central and east Perth Medicare local. They've identified that GPs, well, let's talk about GPs for a minute. GPs are the only clinician for about 40% of people with severe and persistent mental illness in Australia, for a whole variety of reasons. Some people haven't made it to the mental health services, more have made it to the mental health services, didn't like what they saw and found an alternative way to get medical help. GPs look after tens of thousands of people who have severe and persistent mental illness in Australia. And they knew that in the Central and East Perth area, but they also knew that hardly any referrals come from GPs to programs other than Better Access and ATABs. How do we get GPs to behave differently? There's a whole variety of ways to go about that. They decided to use their Medicare local-based continuing professional development points systems, the things they run for GPs, and focus them on the Partners in Recovery program. They have so far had 80 GPs through evenings where they have 2 hours talking about the Partners in Recovery program, and their referrals have spiked immediately. That was paid for, a nice evening meal, probably a few bottles of wine, and preparation of materials to hand out to the GPs, built for them. It was paid for by flexible funding. Now, those are both very different examples of getting on with the job that other people have failed to get on with. If you look at GPs, for example, in relation to FAMs, I was just looking at the figures on the way over in the plane. I've got them from the Department of Social Services. About 1.8% of referrals to FAMs come from GPs, and yet it's custom built for the point they get to in their consultation where they can clearly see that the person needs more in the way of community supports. They've given up on the public mental health services. GPs have a very dark view of the public mental health services, so they don't want to make a referral there. They don't know where else to refer to. They do nothing. A program like FAMS is custom built for their next move, but they don't know where it is. They've never heard of it. They don't understand it because it's not clinical. Perth, Central and Eastern PIR are doing something about it. I just wanted to amplify that point about GPs for a minute. Who do you think prescribes antipsychotics in Australia? Psychiatrists prescribe 16% of them. You know, I've been talking about this to drug companies lately. Whenever they go to look at the effectiveness of a drug or the development of a new drug, who do they talk to? They talk to psychiatrists. Psychiatrists are not the main game. Most antipsychotics are in fact prescribed by GPs. And the interesting thing about GPs is they talk to nobody else. This is going back to my early point about do we know how many people are out there? No, we don't know how many people are out there. And one of the key reasons is that the major clinical group who deals with clinical services for people is GPs who don't talk to anybody else. The only reason we know this is because we can get the data out of the PBS and find out who's prescribing. But how many GPs are dealing with people with severe and persistent mental illness? There isn't a data set. That's a big piece of work to be done. Is there a PhD student out there looking for a piece of work? It's a very important piece of work. Ian Hickey from the Brain and Mind Institute reckons that about 40% of people with schizophrenia only see a GP. GP land matters. Okay. Going around to support facilitator meetings, admittedly 3 or 4 months ago now, these are all sentences that I heard. Richard's seen me deal with this a couple of ways. One was, what do you think of them? The other was to tell you they're wrong. Well, I'm going to tell you they're wrong, partly because of time. These literally are some belief systems that a number of support facilitators came into this program with. That you've got to start with the mental illness. That's clearly wrong. You start with where the person is. You start with their list of priorities. If you're focused entirely on being a person who cures mental illness, you're in the wrong job if you get into Partners in Recovery. You're part of the recovery team that's starting where the person is. Some support facilitators and some whole teams have been obsessed with the idea of communities, of their personal safety in dealing with this group of people. To me, that reflects their complete lack of experience in community work. You know, the meaning of the word clinical is working in a clinic. That's not an entirely accurate description of many clinicians, I hasten to add that. But many of the people who come into this program haven't actually worked out on their own in the community before. And they take on some of the attitudes you get in some of the hospital outreach programs, where people are used to being in big teams, supervised by one of their own discipline, and going around in twos everywhere where there might be a risk. Those sorts of attitudes. If that's where you're starting, your first big issue to solve is, will we be safe? Then you're in the wrong program. I've heard this one in varieties of it repeatedly. Honestly, if you want to work with the too hard basket, you want to do it because you love the idea. Because you're challenged by these people, but at the same time you're amazed by their capacity to survive. That it's a two-way street in which you're learning more about the way that people get by in this world at the same time as you're giving some help to the person you're working with. If you don't find that mutually satisfying, this job's going to be a very short burnout time for you. But there are people saying those sort of things. This stuff about only clinically senior people can supervise support facilitators worries the hell out of me. What does a clinician know about Centrelink and being broke? And what do many of our own NGO managers know about those things? The skill sets will be hard to find, but saying that the safest bet would be to go for senior clinical people to manage is a really dumb decision, a really dumb decision. Believing that that's where expertise and safety and better chances of recovery lie is a really blind alley in this field. And finally, there are clearly people who don't get it. This is a transitional program. This is working out how to build capacity around a person wherever possible using their existing supports and value adding to them so that you can step away and say, we did something useful. It is not about leaping in. I've heard this referred to as being a bit like a homicide, where, you know, people get murdered out here at Meldrum or somewhere, and the local cops start the thing off, and then suddenly the homicide squad arrives and says, out of the way, the experts are here. That sort of thinking will kill this program. If Partners in Recovery becomes another waiting list for people to get one-to-one help, all the critics will have turned out to be right, that coordination wasn't needed, and that we didn't know how to do it anyway. That is a death sentence for PRR if your clients are still with you in 3 years' time. That's just our member organisations. As I go around the country, I'm getting more and more hopeful about PIR. But I wanted to note something that I was talking about with Richard at the break. This current government inherited it from the previous government, and I have to say, uniformly the ones that I've talked to in senior positions, is that they've got grave doubts about this program. It sounds like another crazy Labor idea. And that's a real problem because the Department of Health is full of executives who are all concerned about whether their job's going to be slashed, because there's a target of reducing the Department of Health staff by 6,000 people. So everybody, including the people who run the mental health branch, are thinking, am I next? In that context, who do you think's got the marketing brief for PIR? And the answer is there's no one left but you guys. No one's out there pushing the benefits of this program. No one's out there pushing the fact that it needs at least 3 years to see whether we can make these ideas work. No one's out there telling the stories, and they're already starting to emerge, of success stories. In the meeting that I was referring to, Richard and I were in the other day, there was a carer there saying that her son, who has been in a destructive spiral with everything going wrong that you could imagine, including very serious threats to her own physical safety, has engaged with the Partners in Recovery program, and in a time of 3 months has had the best turnaround that she could remember. She was effusive, life-saving. So those stories are starting to happen. That particular woman is quite influential and goes to lots of meetings with politicians. We need heaps of them. Can I just talk about your critics for a minute? There are lots of them. Organised medicine's the main one. I spoke to 100 psychiatrists a few months ago in Sydney, and it's the most hostile audience I've spoken to in years as I tried to explain about Partners in Recovery. It was $500 million that had been ripped off clinical care that works. based on a flimsy idea that's been proven not to work. Cochrane reviews showed that case management is useless, etc. Really hostile. So, a conventional approach by a Minister of Health is who's the top psychiatrist when you want to talk about what's working in mental health? Well, I hope it's none of those guys to talk to about whether partners in recovery is a good idea. GP land. The AMA is GP land. The Medicare Local Association doesn't really speak for GPs, so that's the AMA. The AMA is very, very sceptical about partners in recovery. So who should you think about? Those are two obvious ones, psychiatrists and GPs. I suggest there's not much you can do about psychiatrists, but there's a lot you can do about GPs. There's a lot you can be doing about GPs in your region to turn their scepticism around. And particularly it's stories, and particularly it's finding out ways of connecting with them. Get your first referral somehow or other. It will be from an established hero who already works with lots of people with severe and persistent mental illness, but get those referrals from GPs. It's critically important to the survival of the program. And it's also entirely good sense because there are so many people who fit your client group who are there. The second group I would go for would be carers. Politicians, whenever I speak with politicians, they'll tell me a story about something dreadful that's happening. They got that story from a carer, not from a consumer, not from a psychiatrist, not from a GP. They got it from a carer. So think about who the carer groups are in your area. Think about the stories that you're creating that carers will carry around the place. They are critical to you. They are going to be your critical marketing tool. They are knocking on the door of every electoral office in Australia all the time. But the third group I'd think about, which is the obvious elephant in the room, is the local state-funded mental health service. One of the things about this program was that Mark Butler went straight past the usual advisory mechanisms. The usual advisory mechanism is the Australian Health Ministers Advisory Committee, which has got a subcommittee made up of all the directors of mental health. And he didn't even talk to them. His belief was, as I work it out, that if he did, they would say this wasn't the highest priority, or that it should be run by them in the state mental health services. He didn't. And they haven't really forgiven him. So we designed a model in which, because they're not an NGO, they can't be on the consortium. Fundamental, I think, with Partners in Recovery is that you've got an excellent working relationship with your local mental health service, that they're making referrals to you backwards and forwards, that you value each other in all sorts of ways. So I would say concentrate on your GPs, concentrate on carers, and get a really good working relationship going with your local mental health services. They will all advertise your work for you, and we need it. Will this go past 3 years funding? No one had thought about it very much. I've always thought that the program probably needed at least 5 years to demonstrate whether it could really significantly change the system. And I think that's probably what Mark Butler was thinking too. At the moment, you've got a government that's counting down the days to 3 years since last year. What is it now? Probably about 2 years and 8 months or 7 months or 6 months. That is not a long time to turn their perceptions around. There are advocates at all sorts of levels, but you're going to have to be very effective communicators. Your PIR needs a communication strategy that works across this region, so that particularly those three groups I was mentioning, whenever they're asked about it, say, this program is starting to kick goals, it's really promising, it needs a chance to grow. If you can't create that environment, we're in trouble. If you can create this environment, it can be one of the most exciting changes that you'll have seen in a lifetime in this field. Thank you very much.